Good afternoon. I am Dr. Manoj, working as assistant professor in departments of Ops and Radio in Lakshmi Narayana Institute of Medical Science, Pondicherry. Today I am talking about heart disease in pregnancy. These are the headings I will be discussing: epidemiology, cardiovascular physiology, and effects of pregnancy in heart disease, and effects of heart disease in pregnancy, and labor progress in heart disease. So overall, the incidence of heart disease in pregnancy is 0.1 to 4%. And coming to developed countries in India, like this, it's mostly rheumatic heart disease, which comprises of 56 to 89%. Developed countries, the most common cause of heart disease is in pregnancies, congenital heart disease, and shunt lesions, and later it is hypertensive disorders in pregnancy. So, heart disease is leading cause of death in women of 25 to 44 years, and is also the most common cause of ICU admission rates, which is almost 6.4 per 1,000 deliveries, and the maternal mortality is up to 2.1%. And what are the physiological changes that occurs in pregnancy in heart disease patients? So when it comes to normal physiological changes, there is increase in cardiac output by 40 to 50%, and along with there is increase in plasma volume by 40 to 50%, and there is increase in stroke volume by 30 to 50%. Along with there is increase in heart rate up to 10 to 20 beats per minute, and heart size up to 30%. And there is along with that there is decrease in systemic peripheral resistance, and also there is a decrease in both systolic and diastolic blood pressure. This heart rate, stroke volume, and cardiac output starts increasing from 50 weeks and peaks up to almost 24 weeks. After that, it becomes later. So, as we discussed, physiological changes in pregnancy, plasma volume increases by 40% in pregnancy. Then half of this will take place in by 4 weeks, and the rest by 20 weeks of gestation. So in early pregnancy, there is a decrease in systemic vascular resistance, and there is increase in heart rate, which is the responsible for increase in cardiac output. So what are the physical findings that is normal in pregnancy, where you can differentiate between patients with heart disease and normal physiological changes? So as we know, whenever we examine a heart disease patient or any heart disease person, we have to do inspection, palpation, and auscultation. So in inspection, what do we find? Which are physiological normal findings in pregnancy? There may be hyperventilation, peripheral edema, distended neck veins with prominent A and V waves, and brisk extent Y descents, and there is capillary pulsations. In precordial palpation, there is brisk, diffuse, and displaced left ventricular impulse, and there is palpable right ventricular impulse, and also there is palpable pulmonary trunk impulse. On auscultation, there is in pulmonary basilar veins increased S1 with exaggerated splitting, and there is mid-systolic ejection type murmur at lower left terminates over the pulmonary area. And there will be continuous murmur, also known as cervical venous murmur, Lambert shuffle. So, apart from that, these are the indicators of heart disease in pregnancy. Whenever there is cyanosis, clubbing, or systolic murmur grade more than 3 by 6, or there is presence of diastolic murmur, and if there is a cardiomegaly or a persistent split S2 or persistent arrhythmia, and there is equivocal enlargement of heart in X-ray, and presence of arrhythmias, atrial fibrillation, or flutter. All of this indicate heart disease in pregnancy. So what are the changes we see in imaging? In ECG changes, there is left axis deviation, and there is sinus tachycardia. There can be ST and T wave changes in inferior leads, and small q inverted P or T wave in lead 3. In chest X-ray, there is straightening of left cardiac border. There is a horizontal positioning of heart. There is increased lung marking and small dural effusion early postpartum. In echo, there can be slightly increased end gastric volume and end systolic volume, and slightly improved left ventricular function, enlargement of ventricular dimensions, slight enlargement of left atrial size, small pericardial effusion, increased tricuspid annulus and diameter, annular diameter, and functional tricuspid regurgitation. So, what are the physiological changes? All of this we saw physiological changes in during the trimester, first to third trimester, and we learned about what is the normal physiology and normal pathology. Now we can study about physiological changes during labor. So during labor, what happens? Because of uterine contraction, there is auto transfusion of 300 to 500 ml. And because of metabolic position and because of pain, anxiety, stress, there is increased cardiac output by 50 to 60%. And along with that, if the patient is receiving anesthesia or analgesia, that also increases on has an effect on cardiovascular system. And breathing and postpartum also has an effect on heart. So during early labor, there is increase in 15% of cardiac output. In stage 1, there is 25% of increase in cardiac output, and in stage 2, there is 50% of increase in cardiac output. So by understanding this, we can know that the patient in second stage of labor has the highest chances of going into failure. So what are the physiological changes that occurs after delivery? So cardiac output increases by 80% because of uterine invalidation and resorption of leg edema. And also there is hemorrhage, which induces additional cardiovascular stress. So what is the effect of heart pregnancy on heart disease? It can cause congestive cardiac failure, pulmonary edema, and sudden death. So after understanding the physiological changes in pregnancy, we know that there is increase in cardiac output since 6 weeks, peaking at 24 weeks, and plateauing after that. So after knowing this, we can understand that patients can have failure or cardiac decompensation during this period. So what are the causes of decompensation during these periods? During first 6 weeks, it is due to peripheral vasodilation, causing increased cardiac output by 20%. And between 28 to 32 weeks of pregnancy, there is increased volume and cardiac output reaching the maximum. And as we said, in labor, during, and immediate postpartum, there is auto transfusion causing increase in cardiac output. And 4 to 5 days after delivery can be because of the infection that can occur in cardiac patients. So what are the effects of cardiac disease on pregnancy? So it can be preterm delivery, it can be fetal growth restriction, it can be congenital heart disease, almost 4.5 to 0.6%, and there can be chance of fetal death also. So to prevent the complications that occurs during labor or during the progress of pregnancy, the patient needs to be counseled prior conception. So what are the things we have to talk to the patient so that we can prevent all of these complications? These are as follows. We have to explain anticipated complications during pregnancy, delivery, and their risk to mothers and fetus, and advise against pregnancy in certain situations, including contraception, and inform about congenital heart disease in their offspring. So Marfan syndrome have an inheritance risk of 50% regardless of gender of the affected patient. So these are the percentages of uh, congenital heart, mother of congenital heart defect, which can affect the neonatal units. So when we see this, the baby, the mother with ASD has a uh, chance of 4 to 10%, and VSD, which is up to 6 to 10%. After that, there can be aortic stenosis. So, what are the contraindications of pregnancy in a patient heart disease? So, we know WHO classifies heart disease patients into four category: one, two, and four. One, two, three, and four. And WHO class 4 is contraindicated for pregnancy. So what are the disorders that comes under WHO class 4? So the first is pulmonary artery hypertension and severe left ventricular dysfunction, ejection fraction less than 30%, previous peripartum cardiomyopathy, and severe mitral stenosis, and second point 8, and Marfan syndrome with aorta dilated more than 45 mm and aortic dilatation more than 50 mm. Aortic disease associated with bicuspid aortical and coarctation of aorta. So, what are the methods of termination? So, the best way is first trimester in this pregnancy to terminate, and the method of choice is dilatation and evacuation, and we can use both. We can use E1 and E2. We have to reduce the dose and to 100 micrograms in less than 99 weeks, and Carboprost is contraindicated because it has effect on heart. So as I told earlier, these are the WHO classification in risk assessment of heart disease patients. So we have in WHO class 1 pulmonary stenosis, patent ductus arteriosus, mitral valve collapse, and in WHO 2 we have tetralogy of Fowler and atrial or ventricular septal defect. And as we have already discussed about WHO class 4. And in WHO class 2 to 3, we have Marfan syndrome, aorta less than 45 mm, and atrioventricular septal defect. And in WHO 3, there is a moderate left ventricular dysfunction that's up to 30 to 45%. And unrepaired cyanotic heart disease and complex heart disease, moderate mitral stenosis. So, just like any other pregnancy, the patient with heart disease also need to undergo some of the routine investigations, wherein NT and nasal bone scan to be done at 12 weeks to rule out cross congenital anomalies and chromosomal anomalies. NT, we are already know that NT and MB has a sensitivity of 85 to 95% respectively. So the incidence of congenital heart disease with normal leukophoresis is 1 to 1000, 1 in 1000. So whenever a patient whose mother patient who's already has a congenital heart disease, it is better to do fetal echo at 24 weeks of gestation, 19 to 22, and anomalies to be ruled out at 19 to 22 weeks of gestation, and along with that, a detailed full echocardiography has to be done at 24 weeks of gestation. Detailed scanning of the fetal anomaly to look for associated anomalies also need to be ruled out, and fetal karyotype with screening for deletion in 22q11 when conotruncal anomalies are present. And all of these patients need to be delivered in institution. Coming to obstetric management of heart disease patients in pregnancy. So we need to know about the frequency of visits, ultrasound, and hospital admission, time and mode of delivery, and what are the things we need to keep it in mind during labor pregnancy. So, accordingly, the frequency of visits during heart disease should be 2 weekly. We know patients with uncomplicated patients who are uncomplicated should have a minimum of 5 visits according to WHO. But in this case, the patients with heart disease need to visit the hospitals every 2 weekly. And during the visits, we have to ask certain questions regarding symptoms and signs of cardiac failure, and we need to monitor vital signs and weight gain, and we need to obtain anesthesia consultation prior to delivery, and we have to discuss contraception post delivery. And if there is an increased risk of IUGR, we need to monitor ultrasound 2 to 4 weekly and fetal surveillance after 30 to 44 weeks. So what are the general objectives of treatment? So in shunts, we need to avoid favoring right to left shunting, causing lower PA pressure, avoid hypoxemia, avoid prolonged vascular. In obstructive lesions, beta blockers need to be avoided, avoid volume depletion, maintain period. And in congestive heart failure, we need to use diuretics and reduce after labor. In arrhythmias, we need to make sure we control weight and rhythm and anticoagulation as necessary, and higher dose of digoxin. What is the admission? What are the admission criteria for a patient with cardiac disease? And so, in what? How do we? When do we admit? So, when do we admit patients with cardiac disease? So, elective admissions in class 1 to 2 are at least 2 weeks prior to expected date of delivery. And in class 3 and 4, as soon as pregnancy is diagnosed, the patient should be kept in hospital throughout pregnancy, which is impossible, but we need to do it. And when a patient comes in emergency, we need to assess about the deterioration of the functional breathing and whether there is appearance of dyspnea or nocturnal cough or arrhythmias, and appearance of any pregnancy complication like anemia, preeclampsia, and pulmonary hypertension. So it is very important to admit a patient comes with it is very important to admit a patient with heart disease who comes with the complaints of any dyspnea or cough or any associated anemia, preeclampsia, or pulmonary hypertension, because all of this will push the patient to failure. So, if in the we also have to keep it in mind about mechanical valve patients with mechanical valve on oral anticoagulant. We need to switch it to from warfarin to heparin in first trimester, and switch back to switch back at 32 36 weeks of gestation prior to delivery. So timing of delivery is not mandatory, and the preferred method is when patient comes to you with spontaneous labor, and it is individualized according to severity of maternal disease and any other fetal compromise. In cyanotic heart disease, there can be significant IOGR may warrant premature terminatus, that may be 37 to 38 weeks of gestation. And women with mild unrepaired congenital heart disease and with successful cardiac surgical repair treated as normal pregnancy. So European Society says cardiac patients with cardiac disease can be induced electively at 40 weeks of gestation, which helps in reduction of cesarean by 10% and stillbirth by 50%. So mode of delivery, vaginal delivery is safer except certain situations and unless there is an indication, fitting indication for cesarean. So what are the method of induction which we can use in patients with heart disease. Both misoprostol and dinoprostol can be used safely, and oxytocin and but in active congenital disease, dinoprostol is contraindicated, cardiovascular disorder, and in cyanosis, Foley catheter is preferred. So, how do we monitor labor in cardiac disease patients? So, we need to general considerations during labor, delivery in anterior and infective endocarditis prophylaxis. So, what are the general considerations we have to keep it in mind during labor? So, we need to make sure there is no tachycardia and increased. We should reduce the effects of, as we know that there going to be a increased cardiac output, and along because of pain there can be increased tachycardia. We need to make sure that we have to reduce the effects of tachycardia and increased cardiac output in labor, and we should ensure there is effective analgesia and anticoagulation whenever there is needed in a pregnancy with prostatic labs, and to cut short second stage of labor and to manage PPH. So, pain relief reduces tachycardia, myocardial work, and also decreased cardiac output. And there should be restriction of IV fluid to less than 75 ml per hour. And there should be oxygen inhalation, and there should be saturation monitoring. And infective endocarditis prophylaxis whenever needed, and FHR monitoring, prevention of postpartum pulmonary edema, and avoid methergine and bolus oxytocin, but also need to prevent PPH. Avoid difficult instrumental delivery. So, what is the position that we have to keep the patient when she is in labor? So, consider lateral decubitus position in obstructulation, and consider supine position with congestive heart failure, reducing vascular resistance, and so cardiac workload. So, individual cardiac disorders has separate positions of the patients during labor. And during labor, the mother with significant heart disease should be kept in semi-recumbent position with lateral tilt. So, uh, which are the heart diseases where we can prefer epidural analgesia? So, analgesia is preferred in ER, MR, or left to right shunts, which is aortic regurgitation, mitral regurgitation, and it is poorly targeted in or limited ability to increase systemic vascular resistance, and right to left shunts, AS, MS, and hypertrophic cardiomyopathy, and pulmonary stenosis without AST. So, what are the things that we should keep in mind in first stage of labor? Uh, the patient should be confined to bed with lateral recumbent position to minimize aortic cable compression, oxygen by mass, analgesia, majority by epidural. Okay, we have discussed about which patients tolerate well epidural analgesia in the past, and the fluid should be restricted up to 75 ml per hour to prevent pulmonary edema, and we need to make sure there is concentrated synthosis augmentation. And like routinely, there should be watch of pulse and respirate every 15 minutes, and there is frequent chest auscultation every 30 minutes to assess any features of failure. And also there should be cardiac monitoring, and pulse oximetry can detect arrhythmia and hypoxia. So, increase in pulse rate above 100 beats per minute or respiratory above 24, particularly when associated with may suggest impending cardiac failure. So, what are the things which need to keep it in mind in second stage of labor? Delay in second stage of labor to be, uh, we need to cut short second stage by either forceps or venous application with Pudendal or perineal gland. So sometimes Ventos can be preferred as it is applied in lateral recumbent position, And prolonged Valsalva increases pulmonary artery pressure, increases right to left shunting. And pulse rate and respiratory rate to be checked every 10 minutes. So what are the things we should keep it in mind once the patient has delivered the baby? So we have to follow active management of third stage of labor, which is giving 10 minutes oxytocin immediately after delivery. And we should make sure that uterus is contracted, and we should make sure that there is controlled contraction. And it is preferable to administer oxytocin in an IV drip to all cases for knotting failure, and simultaneously you need to give furosemide 20 milligram IV to relieve volume overload. And slight blood loss is beneficial, and if in excess oxytocin infusion may be, and if in excess oxytocin infusion may be continued. So episiotomy to be repaired as early as possible to prevent any further in future infections, and the patient should be kept in proper position with oxygen supply throughout. If respiratory distress develops, secondary to pulmonary hypertension or congestion, should be treated aggressively as pulmonary edema. So how do we prevent PPH, and what are the things we can do in postpartum? Slow IV infusion of oxytocin, which avoids systemic hypotension, is administered after placenta delivery to metal hemorrhage. PGF2 alpha analogs are useful to treat postpartum hemorrhage unless an increase in pulmonary artery pressure is undesirable. Methergine is contraindicated because it increases risk of vasoconstriction and hypertension, and there should be we should provide the patient post-delivery stockings to prevent any risk of thromboembolism. And we need to be very careful in the first 12 to 24 hours of delivery, because there is a hemodynamic shift, and which can result in heart failure in patient with cardiac disease. And the patient hemodynamic monitoring should therefore be continued for at least 24 hours of delivery till maximum to 7 days before planning to discharge. So what are the things we have to keep in mind when we are managing a patient post delivery? We have to keep it in mind about pulmonary edema and congestion and any infection. As I told, patient after delivery, the reason for cardiac failure is can be infection. Make sure the patient is not disturbed too much by visitors, and breast when the feeding is not contraindicated unless there is failure. And patients on warfarin should be allowed to breastfeed and need to be restarted as early as possible with apparent withdrawal. And these are some of the contraceptive methods which we can use. So condom has no contraindication in heart disease patients, and pregnancy. Uh, half an hour. 25 minutes. Wait, I started at 3:45. 2:45. They can edit for this part. So combined oral contraceptive pills need to be avoided because there is increased risk of venous thromboembolism, or in a patient with cyanotic heart disease or heart failure or arrhythmia. And progesterone only pill is used in is contraindicated in patients who are using bosentan in pulmonary artery hypertension. And when it comes to implant, copper IUCD is preferred, and sterilization is the best method if the patient is uh, physiologically there is no complications, and it's better to do male vasectomy than your patient undergoing sterilization. Next, infective endocarditis prophylaxis. So oral, we can use amoxicillin, which can be single dose 30 to 60 minutes before the procedure. And unable to take oral medication, we can give ampicillin or cefazolin or ceftriaxone. And if the patient is 2 gram IM or IV, 1 gram IM or IV, If the patient is allergic to penicillins, we can give oral cefalexin or clindamycin, 500 milligram cefalexin oral per hour, 600 milligram per oral clindamycin and azithromycin 500 milligram per hour. If the patient is allergic to penicillin and unable to take oral medication, you can give cefazolin or ceftriaxone 1 gram IM or IV or clindamycin 100 milligram IM or IV. Anaphylaxis to penicillins, you can give clindamycin 600 milligram oral IM or IV, and if enterococcus infection, you can give vancomycin. As I told, so this is a prophylaxis we need to be keep it in mind to prevent infective endocarditis in a patient with heart disease. So after this, so after this is the end of the heart disease in pregnancy. So what are the things we need to keep it in mind in a patient with heart disease? First and foremost, important thing is we need to know the type of lesions the patient has, and we need to counsel according to it. And we know that WHO class 4 is contraindicated for pregnancy. If at all the patient conceives, it's better to terminate in the first trimester. And we also told how the physiological changes that occurs in pregnancy and what is the most important, what are the gestational age where the patient can undergo failure, and what are the causes of failure in individual gestational age. And apart from that, we also discussed regarding the progress of labor, what are the things we need to monitor during the process of labor, and how to prevent uh, the heart failure in a pregnancy. And also we discussed about the prophylaxis for to prevent infective endocarditis. So thank you.